Welcome to this Step 3 review on preoperative evaluation. This video is brought to you by Roadmap to Residency. Preoperative questions are a favorite on Step 3 because they put you in the role of the physician clearing a patient for surgery. The exam wants to know whether you will proceed, optimize the patient first, delay the case, or order something that is simply not needed. Our goal today is not to reteach all of preoperative medicine. It is to show you how these stems are built around cardiac risk, pulmonary risk, medication management, and fasting rules, and how to attack them quickly. Make sure you are also working through your question bank and a solid review resource alongside this video, because these patterns are best learned by doing many practice questions. Let us get started. Here is what we are going to cover today. First, we will sort cardiac and pulmonary risk so you can decide quickly whether a patient is ready for the operating room or needs to be optimized first. Second, we will manage the two medication groups that the exam loves to test: blood thinners and diabetes medicines in the days around surgery. Third, we will lock down the fasting rules before anesthesia and learn to spot the unnecessary testing trap, where the exam tempts you to order a study that a stable patient simply does not need. Along the way, we will walk through several practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to figure out the decision the question is really asking before you do anything else. Start with the last line of the stem. Almost every preoperative question is secretly asking one of four things. Should you proceed straight to surgery, optimize the patient with treatment first, delay the case for more workup, or simply order nothing extra? Once you know which of those four the question wants, the answer choices sort themselves quickly. Then anchor on the size of the operation. Low-risk procedures like cataract surgery and minor skin cases almost never need extra testing, while major chest, abdominal, and vascular operations carry real risk and may call for optimization. The very same patient can be cleared for a small case, yet need attention before a big one. Let the question being asked and the size of the surgery guide how aggressive your answer should be. Strategy 2 is how to handle cardiac risk, which is the most heavily tested piece of preoperative evaluation. The exam expects you to use the revised cardiac risk index. It counts 6 things: high-risk surgery, a history of coronary heart disease, a history of heart failure, a history of stroke or a similar event, diabetes requiring insulin, and impaired kidney function. As you read the stem, simply tally how many of these the patient has. The more present, the higher the cardiac risk. The second clue is even more powerful, and that is functional capacity. If the vignette tells you the patient can climb 2 flights of stairs, walk up a hill, or do vigorous activity without chest pain or shortness of breath, that is good functional capacity. In that situation, you can almost always proceed to surgery without ordering a stress test or an echocardiogram. The exam plants that detail on purpose, hoping you will order a test the patient does not need, recognize it, and choose to proceed. Now let us turn to pulmonary risk, which the exam tests in a quieter but predictable way. First, spot the risk factors as you read. The classic ones are chronic lung disease, current smoking, older age, heart failure, and surgery near the diaphragm, meaning upper abdominal and chest operations. When the stem stacks several of these together, it is telling you the patient is at higher risk for lung complications after surgery. Second, remember that the best answers reduce risk rather than just measure it. Stopping smoking well before the operation, treating an active wheeze or infection, and teaching lung expansion breathing for afterward are the high-value moves. Third, beware the routine testing trap. The exam loves to offer a chest film, breathing tests, or blood gas sampling for a stable patient whose chronic lung condition is at its usual baseline. It feels thorough, but in a patient with no new symptoms, it does not change management, so that testing choice is almost always the wrong answer. Let us work through our first practice question, and this one tests cardiac risk assessment. A 68-year-old man is being seen before an elective hip replacement. He has high blood pressure and diabetes controlled with pills. Importantly, he has never had chest pain, heart failure, or a stroke, and his kidney function is normal. He gardens and climbs 2 flights of stairs every day without any chest pain or breathlessness, and his examination and electrocardiogram are normal. The question asks for the most appropriate next step. As you read, count his cardiac risk factors and pay close attention to that line about climbing stairs. Read the 4 options carefully and pick your answer. Then we will walk through the reasoning together on the next slide. Let us break this down step by step. First, spot the pattern by counting risk factors. His diabetes is controlled with pills, not insulin, so it does not count toward the index, and he has high blood pressure but no coronary disease, no heart failure, no stroke, and normal kidneys. His cardiac risk is low. Even more important, he climbs 2 flights of stairs every day without chest pain or breathlessness, which is the textbook description of good functional capacity. Second, apply the rule. A patient with good functional capacity who can climb 2 flights of stairs without symptoms does not need stress testing before surgery, no matter how big the operation. You simply proceed. Third, eliminate the wrong answers. Ordering a stress test or an echocardiogram is the testing trap because he has already shown you he can exercise. Cancelling the surgery and sending him to a heart specialist is far too aggressive for a low-risk, symptom-free man. The correct answer is choice A, proceed to surgery with no further cardiac testing. Notice how functional capacity pointed you straight there. Here is our second practice question, and this one tests pulmonary risk reduction. A 60-year-old man is scheduled for an elective open repair of a large abdominal hernia in 6 weeks. He has smoked 1 pack a day for 40 years and has a chronic morning cough, but no fever, no weight loss, and no new breathlessness. His lung exam shows mild scattered wheeze that is at his usual baseline. He asks what would most lower his risk of lung problems after surgery. Notice that the surgery is 6 weeks away, that he is a current smoker, and that his lung findings are stable, not new. Read the 4 options and choose the action that actually reduces his risk. Then we will reason through it together on the next slide. Let us break this one down. First, spot the pattern. He carries the major pulmonary risk factors, a long smoking history, chronic lung symptoms, and major upper abdominal surgery. But look closely. His wheeze is at his usual baseline, with no fever, no weight loss, and no new breathlessness. There is no new lung problem to investigate. The question specifically asks what most lowers his risk, not what test to order. Second, apply the rule. The single most effective thing a smoker can do to cut lung complications after surgery is to stop smoking, and the longer before the operation he quits, the greater the benefit. With 6 weeks until surgery, there is real time to make that count. Third, eliminate the wrong answers. Ordering breathing tests or a chest scan is the testing trap because his findings are stable and the results would not change what you do. Cancelling the operation simply because he smokes punishes him and ignores a risk you can actually reduce. The correct answer is choice A, stop smoking as far before surgery as possible. Now let us cover medication management, which is one of the most testable parts of preoperative care. Think in groups. First, blood thinners. Warfarin is usually stopped about 5 days before surgery so that clotting returns to normal, and whether you bridge with an injectable blood thinner during that gap depends on how high the clotting risk is. For example, a mechanical heart valve or a recent clot. The newer direct oral blood thinners are simply held for a day or more depending on the specific drug and the kidney function. Second, diabetes medicines. The unifying idea is that the patient will be fasting, so you reduce or hold the drugs that can cause low blood sugar. The pill that can drop sugar dangerously is held on the morning of surgery, long-acting insulin is usually given at a reduced dose, and the short-acting insulin that covers meals is held until the patient eats again. The popular first-line diabetes pill is generally held around surgery, mainly to protect against problems if kidney function drops or contrast dye is used. Third, and this is the trap, keep the heart and blood pressure medicines going, because stopping those abruptly causes its own harm. The exam wants you to pause only the drugs that cause bleeding or low blood sugar. Here is our third practice question, and this one is about anticoagulation. A 70-year-old woman takes warfarin for atrial fibrillation, an irregular heartbeat. The 2 details that matter most are that she has never had a stroke or a blood clot, and she has no mechanical heart valve. She is scheduled for an elective colonoscopy with possible polyp removal in 1 week, and her clotting level today is in the usual target range. She asks how to manage her warfarin. As you read the choices, notice that her reason for being on warfarin is a relatively lower risk one, and ask yourself whether she truly needs bridging. Pick your answer, and we will reason through it together on the next slide. Let us work through this answer. First, judge the clotting risk, because that single judgment decides everything. Bridging with an injectable blood thinner is reserved for patients at high risk of clotting, such as those with a mechanical heart valve, a recent blood clot, or atrial fibrillation together with a prior stroke. This woman has atrial fibrillation, but she has never had a stroke or a clot and has no mechanical valve, so her clotting risk is low. For a low-risk patient, you simply stop the warfarin about 5 days before the procedure and restart it afterward with no bridge. That is choice A. Now, why are the others wrong? Bridging with heparin is the trap, because in a low-risk patient, it adds bleeding risk for no real benefit. Continuing warfarin straight through a procedure where polyps may be removed invites bleeding, and stopping warfarin permanently to switch to aspirin throws away her stroke protection from the irregular heartbeat. Each wrong answer either overtreats or underprotects. The correct answer is choice A, stop warfarin about 5 days before with no bridging. Let us talk about fasting before anesthesia, because the rules are simple to memorize and the exam tests them precisely. For a planned operation, learn the windows. Clear liquids are allowed up until 2 hours before the procedure. A light meal and breast milk. Stop about 6 hours before. A full meal or anything fatty or fried stops about 8 hours before. When a question gives you the exact time of the last meal, all you have to do is compare it against these windows and decide whether it is safe to go ahead. Now here is the key twist the exam loves. These windows only apply to elective surgery. If the case is a true emergency, you do not wait for the stomach to empty. Instead, the anesthesia team protects the airway using a rapid sequence approach and treats the patient as though the stomach is full. So whenever the STEM describes a life-threatening, time-critical problem, the answer is to proceed to surgery now, rather than to delay for fasting. Recognizing elective versus emergency is the whole game on these questions. Here is the pearl that ties this whole video together, and it is a simple 2-step sort you can run on every preoperative question. First, sort the STEM by naming the decision. Almost every preoperative question is secretly asking you to do one of just 4 things: proceed to surgery, optimize the patient first, delay the case for more workup, or order nothing extra. Before you even look at the answer choices, decide which of those 4 the question wants. Naming the decision in your head turns a long, intimidating vignette into one clear question. Second, choose the least drastic step that is still correct. When 2 answers both look reasonable, the exam almost always rewards the calmer, more proportionate move. Good functional capacity means proceed, not test. A stable chronic lung condition means continue, not scan. A fasting diabetic patient means hold the sugar-lowering drug, not every medicine. If you sort the STEM and then reach for the least drastic correct action, you will get the great majority of these questions right. That wraps up our review of preoperative evaluation for Step 3. Remember the core ideas we covered today. Sort every STEM by naming the decision. Proceed, optimize, delay, or order nothing extra. For cardiac risk, count the index factors and lean hard on functional capacity, because a patient who climbs 2 flights of stairs without symptoms can usually go straight to surgery. For pulmonary risk, reduce risk by stopping smoking and treating active problems, and avoid the routine testing trap. For medications, hold the blood thinners and the sugar-lowering drugs that cause trouble while a patient fasts, but keep the heart and blood pressure medicines going. And know the fasting windows cold, while remembering that a true emergency overrides them. The best way to lock all of this in is to drill questions in your question bank under timed conditions and read every explanation, even on the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.